The past year has been a year of disruption, and every healthcare facility has felt the impact. Financial pressure created by COVID-19 and compounded by a critical staff shortage means that we need to do more with less. As an industry, we must rely on predictive and prescriptive analytics tools and cutting-edge lean principles to transform capacity management. Better healthcare is possible through better math. Over the next 2 days, you'll hear from leaders in healthcare and experts in AI, participate in breakout sessions by field of expertise, and learn how your peers are using analytics and AI tools to optimize their core operational processes. Leave with a new understanding of how you can harness the power of data to improve utilization, increase patient access, and unlock capacity. Start working towards your future. Take the first step to transform.
How do we get more from our existing assets in the hospital? This is one of the most pressing operational questions facing the leadership of health systems. The simple truth is that most health systems operate at the edge of their capacity, just like freeways during rush hour. And just like a fender bender during rush hour, any shock to the system will push the health system into a state of chaos and gridlock. The shock could be either on the demand side or on the supply side. The pandemic was a shock on both the demand as well as the supply side. The crisis also put enormous financial pressure on many health systems. This makes it difficult to continue with the old approach of building more hospitals, more operating rooms, more inpatient bed units, and more ambulatory care facilities. The focus has to shift from building more assets to getting more out of the existing assets. Over the past 7 years, we have worked closely with over 450 hospitals, belonging to 120 of the leading health systems in the United States, to prove that this can be done in a rapid and scalable manner. I have the privilege of leading an amazing team of nearly 300 talented individuals with a rich diversity of expertise in mathematics, data science, software engineering, product management, operational excellence, and of course, healthcare. Together, we have raised and deployed over $250 million and built a suite of sophisticated web-based software products that use data science, artificial intelligence, machine learning to optimize the utilization of operating rooms, inpatient beds, and infusion chairs. Collectively, our products optimize 2,200 operating rooms, 4,000 inpatient beds, and 8,500 infusion chairs that positively impact the experience of nearly 200,000 patients every single week. The operational impact that is delivered is enormous. For example, improving the staff room utilization of operating rooms by 5 to 6 points allows many more surgeries to be completed each day, thereby creating tens of millions of dollars of value each year for hospitals with 20 or more operating rooms. Reducing the wait time in infusion centers by 40 to 50% eliminates the problem facing the elderly man with cancer I was telling you about earlier, while unlocking 10 to 15 points of extra capacity. This creates $1 million of value per year for oncology practices that have 50 or more infusion chairs. The value at stake across the country is $200 to $250 billion per year across all 5,000 hospitals. This translates to $40 to $50 million per year for the average hospital. This is particularly relevant now, given the adverse impact that COVID has had on the financial performance of many health systems. So that's why I'm here. I hope to be able to open your eyes to the amount of capacity you can unlock in your hospital today, not next year, not 2 years from now, so that you can serve more patients, reduce the stress on your staff, enhance the patient experience, and improve your financial performance along the way.
Shore up the foundation, continuing to expand the underlying capability set that then will allow us to take advantage of the tremendous opportunities that are brought to us regularly by various members of our broad ecosystem of partners. LeanTOS, of course, one of the reasons we're such good friends is that LeanTOS is it has been a great partner for us. And when we had to think about a business problem, that being all of our operating rooms had been shut down, except for emergency surgeries. All of the elective surgeries had been shut down. And we needed to open up and reschedule a backlog of, hundreds, if not thousands of surgeries. And of course, there's a lot of considerations associated with that. It's availability of surgeons, surgical teams, resources of all different sorts, people resources, things resources, rooms, of course, and their availability. Another big math problem, right? And so who had just helped us solve that crazy math problem related to not having a waiting room in our infusion center? LeanTOS had. So it wasn't a surprise that you stepped up and helped us with the automating the refilling of those ORs. We were up and running, and those ORs were full right away, which was a tremendous gift. And you and other partners in our ecosystem are, and the optimal engagement with those partners is part of our secret sauce at McLaren Health.
I think that we're going to see much faster adoption going forward. I mean, we've been using arithmetic when we need calculus. And I think that's been exposed now. And I think that most systems are now open to the possibility that there's a better way to do things. And I hope that that's the case. And I do believe that it is. And frankly, in some ways, it's much easier to focus on operations than it is on clinical care. And a byproduct of focusing on operations is clinical care gets better. Take it outside the hospital. What if physicians' offices had this type of information management system in place, and they could predict waiting times in the waiting room? Nobody likes to wait in the waiting room for an hour to see a doctor for 10 minutes. It's almost arrogant to take that posture that it doesn't matter. So the experience of the patient, the mindset of the patient coming into the exam, instead of being angry and not being able to focus on what the question was that they had that they've now forgotten because they can't get past the fact that they've been forced to wait for so long. Some may even just get up and leave and say, I'll come back next month. And all of those things add up to worse patient care. And so there's a beautiful symmetry here that if we streamline operations, then we are able to get to patients and give them what they need much more quickly and frankly, much more effectively when we're both in a mindset that allows that dialogue to take place.
I'm going to circle back on this, and for those of you that are listening now, I promise I don't work for LeanTOS. But if it is your goal to increase your surgical volume and you don't work in Chicago, I highly, recommend the LeanTOS software. It's been over a year since we've been live with the program, and not only am I still working with Sanjeev, but the implementation manager, Alyssa, I think I'm on the phone with her, still more than my mother. And we work together on problems that are utilization based, but also scheduling based. I mean, these are people that have worked in the operating room. And if I have a question about how other hospitals around the country are handling a problem or inventing new processes, I'm calling her to brainstorm with. And they are part of our team here now. They are part of our training program here now. And, I'm so happy to have them involved with us, and it hasn't stopped. So I'm happy to still have them hanging around and to have helped us improve.
The support tools that are available through here, again, just looking at the data in different ways has been extremely effective for us to be able to either right size blocks, take blocks away, add blocks, etc. And that's been within 3 months of going live. We were able to make some significant changes that otherwise would have taken us much longer to do. We share the good and the bad. And so, we share the good data to the surgeons that show, how we're improving our staff utilization, how we're improving our first case on start times. But we also share some of the bad data, which is, what is causing the delays in our first case. And is it the surgeons, is it anesthesia, et cetera? And what are we going to do then? What action plans are we going to put around each of those delays? So it's allowed us to capture all of that and then target those opportunities and work on ways to improve.
Science needs to be the driving force around capacity management. It is no longer something that you can do with a pencil and a pad of legal paper. We need to recognize that it has advanced past that and will never go back. Knowing where we were, and then with the real-time understanding, the next obvious step is to see, well, let's not guess anymore. Let's see if we can use data to inform our anticipatory decisions. And staff are tired, patients are sicker, care is more complex, and the care has arrived before we can put in large capital investments in things like buildings. So these are the levers that we really have to pull quickly. Let's bring in some advanced tools. We've gone through all that. We understand each other to a certain extent. Let's see what new levers are out there using forward-looking information to try to mitigate those bottlenecks that we can mitigate, understanding we'll never get to zero.
And I think the results of the tool really speak for themselves. Since implementing it, we've seen improvements in our ICU transfer time, our admit time, notably in our opportunity days associated with our inpatient length of stay, and certainly in the confidence that our organization has in our capacity management leadership and decision making. And all of this happened, all of these improvements happened during the pandemic. I think it's really notable, that timing, because as a lot of those who worked in hospitals know, we kind of stopped a lot of our process improvement and quality improvement projects and reallocated resources to the pandemic response. So the fact that we've been able to see this type of improvement, I think really speaks to just how valuable the tool is.
Overall, we're using our hours in the morning and in the evening much more consistently. So there's less low census for nurses going home early. We're able to have our pharmacy feel very consistent through the day. And we've made some real impact to our ability to kind of increase our patient load despite having fewer chairs. Some additional benefits that we've had is that a LeanTAS application continues to support us in our scheduling decisions. So it provides diagnostics that show us specific metrics which allow us to make changes on a particular day. The metrics provide us details about where opportunities exist to schedule patients, or where there may be challenges due to the way that we are scheduling, if we've scheduled too many patients in one area. And so that allows us to work ahead to ensure a smooth schedule through the day. Nurses have a more consistent work than, like I previously spoke about, and they're not experiencing those peaks and flows that we were prior to implementation. Because of the success that we've experienced in the Rogo Cancer Center, we're looking at expanding IQ to our other infusion sites. We are working with IQ to strategically open a few of our closed COVID chairs. And we are looking to send our schedule changes real time to IQ so that scheduling decisions can be made at point of care. And we want to look at ways that we can smooth our schedule based off of our provider scheduled clinic days. And IQ has been, will continue to support us on our ongoing training of our cancer center schedulers.
These templates that are built to get patients through quickly, decrease wait times, as you can see from this presentation itself, and to really be patient focused. However, that does mean that some of our scheduling practices had to change. So really just helping those schedulers understand why this is actually better for the patient, and then showing them the data thereafter of why it is better, because the patient can get through more quickly without a lot of wait time, and also nurses that are more readily available to help them too, because our templates are more level loaded and much more efficient. Plan to add some fast track chairs to one of our satellite infusion centers, just based off the data that they were able to provide us, which was so incredibly helpful when we went to in front of the business committee to justify the pro forma. That number one was incredibly helpful and something I could have never done before IQ. Also, they will help us partner when we go to get patients scheduled into those chairs to create an efficient process and get patients through both in those chairs and our legacy chairs that we have right now, which will accommodate longer infusions. Kind of comes back down to just reminding our scheduling team to use those templates the way they are built, because they are built to accommodate add-ons, and all, as I understand, all based off that predictive and analytical software that is built into our templates on the background. So even though, again, a particular Monday might feel really, very busy and just no way we could take one more add-on for the day, again, looking at the data, we are now on a real-time data feed with IQ. We have been for several months now, and that's been incredibly helpful too, to just say, if I've got this ill add-on coming in, it's noon, instead of having to base all of my decisions off historical data on a Monday at noon, I can now look at my templates in real time within IQ and see, okay, wow, it looks like we've got a lot of open chairs opening up with some cancellations we didn't expect, and here are the times that it's looking like we could potentially get this patient in based off real-time data versus just historical data. So I think that added real-time data layer has been extremely helpful, and again, has also contributed to our decreased wait time.
Throughout your book, a theme that comes up is the supply-demand matching. You talked about it from information, from testing, and even now when you talk about the labor and the wage pressure, it's a matching of supply and demand. As you know, our whole premise in the products we build is around matching the supply and demand for assets. So we focus more operationally on the assets like operating rooms and imaging and so on. What do you think health system executives need to do to get more sophisticated on the intricacies of supply and demand matching?
Yeah, look, I think that this gets back to some of the other questions. I think that there are going to be a lot of opportunities because we have access to better information and the ability to use predictive algorithms on top of that information to make better estimates of what demand's going to be in healthcare. For example, I think right now we're in a position probably to try to measure some of that excess morbidity, and you're seeing some studies come out trying to do this right now on what future demand's going to be in certain spaces like oncology, where you could sort of make predictions based on past patterns of what the impact's going to be, for example, of the missed visits, the missed routine screening, what the rise in incidence of cancer is going to be. And you're seeing some of those studies start to come out. So I think that there's a real opportunity to use access to data where we have much better access to large data sets, both historical and prospective, combined with predictive algorithms for provider systems to get a more insight into what future demand's going to be. And a lot of you're using those tools. A lot of entities are starting to adopt those tools. I think that you're going to see an acceleration, because this also, this isn't really a regulated space. You're using these tools to sort of inform business decisions, not inform necessarily clinical decisions in the context of a single patient. So this is the real area where you could see more rapid adoption of these kinds of tools, similar to what other industries have done.
In short, I think the lessons that we've learned and that I hope to share with all of you, when we look to leverage technology and artificial intelligence, right, it's a lot of hype often in the media and in the publications that we all receive. Helping organizational leaders really tie this work to the strategies and problems that they're already dealing with and facing is a really important piece in laying the foundation for this work. Again, can't underscore enough the need to partner with clinical and operational champions, that they are sort of at the leading edge of the impact of this. If it doesn't work, the IT team doesn't lose out all that much, but when operations goes sour, it's those clinical and operational champions that really bear the brunt of that. And so their strong partnership, their commitment, and their support is absolutely critical. Focusing on quick wins and building the momentum. So after the first 3 months in the first 2 infusion centers that we deployed, we looked at our results. We were very transparent that it was a short amount of time and just a small subset of the infusion chairs, but we told that story in lots of forums where it was important for other clinical leaders, other service lines, the areas like the operating rooms, even our cath labs, the inpatient beds. We started to build that momentum, to share the success, very practically talk about any of the challenges that we faced. And really our challenges rested in the change management, the operational changes, and trying to do all of that in the middle of a pandemic sort of slowed some of that work down. But important point, again, is to build that momentum, share the story, and let the data sort of speak for itself. Again, really important, choosing that third-party partner who shares your vision. I'll say again, LeanTaaS isn't our only partner, but it's filling a really important need. I personally, my philosophy is neither best of breed. I don't want, 15 or 20 different solutions, but it's not one size fits all either. So that small handful of tools that's going to help you with your problems is really important. And for some of these really big problems that I mentioned, LeanTaaS has been that really strong partner for us. And then, as I said, celebrate the successes, build the commitment, and tell your story. I'm here today to really help share, hopefully, what is some encouraging news and light at the end of what has been a long tunnel around some of these really big challenges.
Having the one way of reporting the data and allowing everybody to look at the data has made a tremendous difference, even in the COVID crisis. I appreciate the customer service you guys have. It's been extremely helpful in getting things launched.
Current state physical space continues to be a constraint for us, and with our volumes ticking back up to pre-COVID volumes, capacity management has been a main focus. We worked with our team at LeanTaaS to explore possibilities for alleviating some of the load, and one of the main areas of opportunity was level loading patients to Tuesdays, which are historically the lowest volume day for us across all of our units. In addition to level loading some of our visits to Tuesdays, we also recently implemented different scripting to align with best practices for scheduling. Historically, our schedulers have asked patients what time they would prefer to come in, and if that time was not available, they just add them to a wait list. And that's frequently the case that the time that they want is not available. So current state, we are offering patients a choice of different available appointments with the hope that one of those times will work for them. And then we can avoid the waitlist process entirely. After the scripting change, we saw an increased utilization of Tuesdays, and we also took our wait list from a high of nearly 500 patients within a 3-month period to a low of under 100.
When we went live with IQ, this would have been the last quarter of 2019. We actually saw a 4.5% increase that first quarter on this campus without having to expand any available time on our grid. We didn't add any additional staff. We didn't add any additional asset in terms of rooms. And then now, as we're kind of coming out of this last wave of the pandemic here locally, we're now able to continue that additional throughput for our patients, and so that we're able to do as many cases as we possibly can.
After using IQ, we saw an immediate increase, almost 70% of in-block utilization and almost 80% staff room utilization. In this current fiscal year, we're so far off to a very good start with over 75% in-block utilization, which I think is very good for an academic medical center.
We noted the 90% improved confidence in critical capacity decisions. So what we meant by that is making decisions on whether our access center will go on a delay or redirect protocol, decline protocol, or even when we talk about delaying procedures, et cetera, during the COVID pandemic. And what we've been able to do is that really using real-time data and predictive analytics that have proven to be phenomenally accurate so that we can make the best decisions. So historically, the decision that I might make as an AOC versus a decision that my colleague might make as an AOC that we make on a Monday versus a Friday. Now we use data and our predictive balance and bed balance to drive those decisions. So there's less gut and subjectivity and much more objectivity into how we're making decisions. So we've been able to do two things. One, stay off of delays and redirect protocols unnecessarily, but two, actually go on them earlier because we can see that we're going to be in trouble. So we've been able to sort of benefit on both ends of that spectrum because we're using that predicted balance to make decisions versus I'm not exactly sure where we're going to end up. The amount of time and what we would do historically, we would go sort of stand up our command center, which was a little room with director, VP level people to go make decisions, to escalate delays, to address barriers. And now that's just SOP. And we don't have to go all sit in a command center and cancel our meetings for the day. We really leverage this tool to guide how we make decisions.
We've been able to set goals for our nurse managers and our leadership teams directly within the product. And the way in which the tool also pulls in the data to compare our current performance against those goals is invaluable, because historically in IQ, we've really been able to measure our performance and understand how we're doing. But it really didn't have that component of explaining or displaying where we should be and whether or not we have a gap between where we are and where we want to be. So this tool really shows us at a glance the different areas where we're either doing well or perhaps not so well.
So some of my key takeaways that I hope we bring away from this is that modern infusion clinic logistics far exceed the capabilities of any single department. So if you feel like well, we can get patients through if we just improve nursing, or if we just improve pharmacy, or we just improve lab, then we've somewhat missed the point of what I'm saying. We're all interconnected in what we do. And really, we all have to find a way to leverage efficiencies and data more effectively, but as a cohesive unit. When they're here, they're coming into our service as an infusion clinic, and that means all of us have equal partnership there. The interwoven nature of oncology demand solutions that address both upstream and downstream logistics. So we can't address one without the other. Pharmacy is a clinical service that has a robust manufacturing operation that's vital to your overall performance. So please, please, please be kind to your pharmacy team and just understand that they're really involved in a lot of aspects. We're not just there to verify the drug and compound the drug. That is a gross underestimation of what we bring to the table. And right now, no acuity exists that can correlate between both nursing and pharmacy demands for an individual patient. And we find that ability to bring that together, and I would also probably add in bringing in that lab aspect of it as well. That's going to be the solution that I think really takes us forward and pushes this from a more cognitive development perspective of what infusion clinics can really operate. They hit the top of their capability.
Okay, so why am I telling you this? Why is this relevant to an infusion center? So I want you now to take each one of these cashiers and assume for a minute that each one of these cashiers is a nurse in your infusion center. And each one of these circles, these customers, is actually a patient that is in her or his queue of patients for the day. So if we assume that most centers do some sort of a pre-allocation of patients, whether it's the night before, whether it's a day of, each nurse will know what their general slate of patients looks like. So in the morning, what they know is basically the same thing that you know when you're standing here waiting to go and chill they are. They have a general sense of their acuity level. They know what the treatment regimen is that they're there for. They know if they're a new patient. They know if they're a clinical trial patient. So they know a fair amount. Just like when you're standing here, you know a fair amount about which line you want to go into. You know how long it is. You know how big the basket is, how fast things are going in terms of that cashier. What that nurse doesn't know, though, is she doesn't know who's going to come on time. She doesn't know who's going to come late. She doesn't know who's going to get stuck in a doctor's appointment that goes for a long time. I refer to times when you have multiple things go wrong simultaneously as wrecks on the interstate. All right, so is that just a permanent condition? It's actually not. So let's look at what the alternative is. So the alternative looks something like this. So now we're going to switch gears and we're going to go to, not to the grocery store, but we're going to go to several specific retailers. In this particular case, it's going to be, you've probably all been to a Best Buy, you've been to a Joann Fabric, you've been to Marshalls and TJ Maxx do it this way. So again, we've got the same 5 cashiers that we had before. The difference is that instead of having each one of them have a fixed line like we had previously, we're going to have everybody queue up and we're going to have everybody queue up into a single line. All right. So you've all seen this before. Again, if you've been to Best Buy or Joann or wherever else. So this is what it's going to look like. Now, what happens in this particular situation? So you've all been in this this situation before. So you know that so let's put all of these folks in line right now. This is roughly the same number of customers that we had in the previous slide. And now each one of these cashiers is going to take the customer as they are available. So I would encourage you as you look to 2022 to think about how a complete change in your approach to how you do your operations might lead to a completely new look and feel of your operations overall.